Good afternoon. I shall be telling you about new targets in neuroendocrine tumors. This is a little different topic than routine cancers which we see, because neuroendocrine tumors comprise a heterogeneous group of neoplasm derived from peptide and amine producing cells of the neuroendocrine system. These tumors may arise sporadically or in the context of a heritable tumor syndrome. These are rare tumors we see in the clinic, and significant clinical challenge, varied presentations. Management is complicated if surgery is not possible, and they could be sporadic or heritable. Now, if we see the biology of NETs, the neuroendocrine tumors, there are at least 14 endocrine cell types in the gut, and these, along with the endocrine cells of the pancreas, produce at least 33 hormones and biogenic amines. These constitute the diffuse endocrine system. You can put endocrine glands separately, but it is a diffuse endocrine system. These cells arise mainly from the multipotential stem cells of endodermal origin in the pancreas and intestinal tracts. Now, if we see the genetics, no clearly identifiable common pattern of genetic aberration has emerged to form a molecular basis for tumorigenesis. Familial syndromes offer some insight. And if we see the heritable tumor syndromes associated with neuroendocrine tumors, and here we see, so if we have this MEN type 1, the gene product is menin, and it is associated, the neuroendocrine tumor is gastrinoma or non-functional NET, insulinoma. With MEN type 2, these are multiple endocrine neoplasias, and this is RET, receptor tyrosine kinase, medullary thyroid cancer, and pheochromocytomas. Neurofibromatosis type 1, it is hamartin, somatostatinoma, VHL gene, which is also mutated in RCCs. And here you see the renal cell carcinomas. This is tumor suppressor protein, VHL, and this is non-functional NET. Then tuberous sclerosis associated with tuberin, and these are also insulinoma and gastrinomas. Now, if we see the clinical neuroendocrine tumor systems based on hormone overproduction, clinically we see like serotonin for carcinoid, and these are the incidence per 100,000 population, and this is incidence in men 1 per 100,000 annually, and specific symptomatic treatment, and the malignancy occurs in this much percentage of cases. And this is with insulin, gastrin, vasoactive intestinal polypeptide, glucagon, somatostatin, and all these hormones. Now, the need to explore different pathways and targets. They are generally resistant to conventional chemotherapy. That is the main crux. And present in advanced or metastatic settings, various pathways are known to be activated, and some of these can be targeted with drugs that are available and have shown promise in other settings. Now, what are the current therapies available? Just to analyze these therapies, somatostatin analogs are there, interferon therapy, chemotherapy to an extent where it is small cell carcinomas, liver-directed therapy, then surgery remains the mainstay of treatment. Most of the patients come after surgery, and ablative therapies like RFA, radiofrequency ablation, radiation, or embolization. And important is peptide receptor radiopharmaceutical therapy using lutetium radioactive isotope lutetium-177. Now, various pathways involved in that are PI3 kinase pathway. Then we have Notch1 signaling pathway, which is becoming important in these cases, especially in pancreatic carcinoids and medullary thyroid cancer. Then RAS, RAF, MEK, ERK pathway, which has been told earlier, and the RET pathway. Now, if we see the PI3 kinase AKT pathway, I won't again tell you because already it has been discussed. And the main targets, downstream components include the NF-kappa B, mTOR, and glycogen synthase kinase 3 beta. And due to many steps involved in the PI3-AKT pathway, it provides approaches for treatment of these malignancies. And PI3 inhibitors showing promise. And we have a GSK3 beta emitter as lithium chloride, which is being studied. Now, mTOR pathway has been discussed earlier. One of the downstream targets of PI3-AKT and the RAS-RAF pathway. mTOR, again, you already know that serine threonine kinase that has been shown to regulate cell proliferation and apoptosis. And these two are, currently approved by US FDA, temsirolimus and everolimus. And everolimus is approved for pancreatic NETs. Now, this is again another important pathway, which is a Notch1 pathway. And the ligand and the notch, once it is cleaved, then ICN is released. It goes to the nucleus and it causes various signaling pathways. Now, with minimal Notch1 signaling present, these cancers express high levels of ASCL1, which makes it useful as a neuroendocrine tumor marker. And Notch1 is a tumor suppressor gene for these cancers, and it is activating agents are being studied. Now, one of the activating agents is valproic acid, which we use for epilepsy. Now, this is a RAS-RAF-MEK pathway, RAS-RAF-MEK and ERK pathway. And here we see this pathway has been shown to be minimally active or absent in neuroendocrine tumors such as small cell lung cancer, carcinoid, and medullary carcinomas. But this pathway may play an important role in tumor suppression via autoactivation but also by interaction with other signaling pathways, as you just heard. And RAF1 activation might be a pathway to be targeted, as in melanomas we have seen. And tautomycin being studied, and leflunomide, its active metabolite, teriflunomide, were shown to decrease the expression of tumor markers and inhibit in vitro and in vivo carcinoid cell proliferation. Now, again, another important is the RET pathway, encodes the tyrosine kinase domain. Downstream signaling includes MAP kinase, fibroblast growth factor substrate 2, and PI3 kinase dependent 5, CDK5. And we have two important drugs like vandatinib and sunitinib, which are multikinase inhibitors. And this is all the drugs which are bevacizumab, octreotide, sunitinib, sorafenib, all these multikinase inhibitors, pazopanib, VEGF, and PDGF, all inhibitors have been tried in phase 2 clinical trials. And some of the trials are ongoing. And this is again a targeted therapy for neuroendocrine tumors. These are phase 2 drugs which have been tried, bevacizumab plus temozolomide, everolimus plus, these are ongoing trials. And again, the target for RADIANT-2 is everolimus plus placebo, which I'll be showing you. RADIANT-3, another important trial for these. And they have shown that octreotide plus everolimus would be a better combination than either drug used alone. And if you see the RADIANT-2 trial, the median progression-free survival, this was a trial, history of carcinoid symptoms, received oral everolimus, 10 milligram per day, plus octreotide LAR, 30 milligram, or placebo plus octreotide. In this, there was no everolimus. And here you see median progression-free survival for 16.4 months vis-a-vis 11.3 months. And so they provided, E plus O, both provided 5.1 month clinically meaningful increase in median progression-free survival. And this safety was acceptable. And this is another RADIANT-3 trial, which has shown, if you see the everolimus versus placebo, again, the hazard ratio was 0.35. Now, if you see the phase 3 trial of sunitinib versus placebo for treatment of pancreatic neuroendocrine tumors, after which the sunitinib was approved by US FDA. And here you see the median progression-free survival was 11.4 months vis-a-vis 5.5 months for the placebo. And so you see the median overall survival not reached. Now, in concluding, what I would like to say that neuroendocrine tumors, various molecular pathways are being explored. It is not only that PI3 kinase or the mTOR pathway or the RAS-RAF-MAP kinase pathway. They are being explored. Successful targeting of some pathways has been achieved, and other targets are also being explored. And combination therapies with reduced toxicities are sought, and individualized therapy is the ideal goal ahead. That means we have to see which pathway is active in which patient, and maybe we are able to personalize the therapy. Thank you very much.